Good evening. I'm Dr. Alex Epelbaum from Integrated Medical Professionals, Advanced Urology Centers of New York, based in Smithtown. I am a practicing urologist for the past 20 some odd years, and I'm here to present to you some information about benign prostatic hyperplasia. So what we wanted to do tonight is we wanted to make it a little interactive. The audience will have a chance to ask questions, but I get to have some fun too. And I get to post some questions for you folks. So let's start with the simple one. What is benign prostatic hyperplasia? And we'll give it a little bit. Well, excellent. So, the answers are quite humorous, but, I see some folks answered all the above. But benign prostatic hyperplasia is the winner. So what is BPH? It is essentially an enlarged prostate. It is a non-cancerous, a very treatable, very common condition amongst men over 50. And over 43 million men in the United States are affected, and more than 660 million men worldwide are affected with enlarged prostate condition. And as men age, that prevalence increases. And our thoughts are that it's possibly due to hormonal changes as men age. The way I like to approach conversation about benign prostatic hyperplasia is really not so much about the enlarged prostate per se, but how does it affect your bladder? And as the prostate grows, it impinges on the lumen of the urethra and occludes the normal flow of urine. I like to refer to the bladder as the pump and the rest of the plumbing as your pipe. And the prostate, as it grows, presents a clog in the pipe that makes the bladder work a lot harder, and over time leads to various different conditions. And the most common symptoms are the sudden and recurrent urges to urinate, difficulty starting the flow, interrupted or slow flow, frequently urinating, getting up at night to urinate, pushing or straining to urinate, and sometimes even leading to urinary leakage as the condition worsens. What we use in the offices, and some of you who have been to our offices, we use something called the International Prostate Symptom Score, which is the urinary symptom score that is very meaningful to every urologist. It allows us to judge the amount of incomplete emptying, urinary frequency, intermittency, urgency, getting up at night to urinate. And then importantly, on the bottom is the quality of life. How bothersome are those symptoms to the patient? And that score goes anywhere from 0 to a maximum of 35. And we have groupings. The under 8 is the mild symptoms, 8 to 20 is moderate symptoms, and 20 to 35 are severe symptoms of BPH. As the condition worsens, it can certainly lead to some complications. Urinary tract infections, bladder stones, potentially kidney failure, urinary leakage or incontinence, and bladder damage as the condition worsens to a point where a patient requires a catheter. What I want to emphasize is that BPH does not increase your cancer risk. Let's move on to our next fun topic. How do you think BPH is diagnosed? So would most of you rather have a cystoscopy or play a golf tournament with Scotty Scheffler? We're getting a tie here. I think we have a lot of golfers on this webinar tonight, but the winner is the cystoscopy. So how do we diagnose BPH? Well, most commonly, we examine the prostate in the offices. As part of the urologic evaluation, we also draw blood for PSA, which determines the cancer risk. We do urine testing to make sure that there's no blood or infection in the urine. We also do a simple bladder ultrasound to measure the residual urine in the bladder after the patient has urinated. Depending on those findings, we can move to more sophisticated testing when we suspect that a patient, based on their symptoms, has BPH. We want to perform what we call pressure flow studies. And there are two different flavors. One is called a Eurocuff, which is a test that quickly determines how well your bladder empties and functions. Urodynamic test is a more sophisticated test that also requires catheters to gather that data. And then we move to more advanced testing depending on the findings of the previous. One is a cystoscopy, where we use, in today's age, a flexible cystoscope, which is a flexible camera that's inserted into the urethra that allows us to examine the bladder and the internal anatomy of the prostate. And we also perform an ultrasound to measure the size of the prostate to determine what kind of procedures the patient may be eligible for. The prostate biopsy is not a diagnostic test for BPH. It is simply reserved for patients who have an abnormal exam or an elevated PSA. Let's move on to our next question. What do you think the lifestyle changes may do for patients with BPH? So the winner tonight is coffee, tea, carbonated drinks, even without caffeine. Actually, that's the winner, but all of these can be a bladder irritant and affect urinary symptoms as well. There are multiple treatment options for patients with BPH. We start with lifestyle changes. We avoid certain categories of medications. We move on to some prescribed medications, and there are certainly multiple procedures that exist for treatment of BPH. The lifestyle changes are exactly what the last poll question was gathering, is we try to avoid fluid intake after certain hours. We try to avoid bladder irritants that will cause a lot of urgency and frequency. You also want to be cognizant of what medications you're taking. Some of the over-the-counter medications, particularly some of the cold remedies, may affect normal bladder function and cause urinary symptoms. There are a number of different medications that we use to treat patients with BPH. Alpha blockers are the most common ones, and most patients may have heard about Flomax, uroxetrol. Some of the older medications like Hitrin and Cardura are still in existence, but those affect blood pressure more so than the Flomax, uroxetrol, and Rapaflo. We also use what we call 5-alpha reductase inhibitors And the two on the market are Avodart and Proscar, with their generic names of dutasteride and finasteride. Just a little humor for you here. So when do we recommend procedures? And that is when the lifestyle changes and medications simply don't work, or patients prefer not to stay on the medications long term. And most insurances will cover various different procedures that address BPH. We follow pathways on how we manage a patient, whether we start them on a medicine and when we move on to surgery. The way I like to talk about the various different treatment options in the BPH is to stratify them by risk versus benefit. We all strive for the least amount of risk and the most amount of benefit. On the left-hand side, you've got medications. They have the least amount of risk and probably not as much benefit as most people would think. The surgery certainly offers more benefit, but there are more potential complications that are associated with surgery. And the vastly expanding field in the BPH treatment space is MIST, or minimally invasive surgical treatments, that are exploding, and we now have 6 or 7 various different options in this space. So how do we approach who needs surgery, who needs minimally invasive procedure? So if we have a patient presenting with an enlarged prostate, they're not able to pee, they may be in renal failure, recurrent blood in the urine, chronic infections, bladder stones, those are patients that are probably will benefit from surgery mostly. In the surgery, we have laser procedures, we have the traditional, what we call roto-rooter procedure, or transurethral resection of prostate. We have robotic or open prostatectomy, and one of the newer kids on the block is aquablation that I'll talk about in a little bit. The minimally invasive space is that same patient with enlarged prostate, but they wish to preserve their ejaculatory function. They are not in retention. They don't want to stay on the medicine. They want more rapid recovery and perhaps do the procedure not in a hospital setting, but in an outpatient setting. And the procedures that are in that space, you have the steam procedure called Resume. You've got the UroLift procedure, iTind, which is a temporary implantable nitinol device, Optilume that came on the market about a year and a half ago, prostate arterial embolization, and there are a few newcomers that are just about to launch out in the market space as well. So I like to talk about treating BPH as if I have a patient in front of me. So Michael presents to the office. He's a 67-year-old gentleman with significant urinary symptoms based on his questionnaire that he filled out that places him in the severe category with an IPSS score of 26. And if you remember, I mentioned it goes from 0 to 35. He had one prior episode of not being able to urinate after his hernia surgery. He's currently taking Flomax, tamsulosin is the generic name, but he wants to preserve maximal sexual function, and he also prefers to stop his medications. So when we consider how we approach selecting the surgery, we want to talk about the efficacy. When we look in the minimally invasive category, and we consider the reduction in the urinary symptom score, we are able to reduce it anywhere from 7 to 11 points. When we're talking about surgical options, we certainly can do a lot better in the way of reducing those urinary symptom scores from 14 to 16. But as I mentioned, there may be some more complications, and we'll talk about them later. So do patients still have to choose between doing the procedure and preserving their ejaculatory function? And that is where some of the data that was submitted to the FDA with the early onset of a lot of these minimally invasive procedures, as you can see on the bottom left, the STEAM procedure, which is the resume procedure, carries about a 6% chance of ejaculatory dysfunction, meaning that the patients are not able to ejaculate after the procedure. And Urolift, the data shows that it's near zero. The aquablation data shows that patients are able to preserve their ejaculatory function 86 to 92% of cases. So when we consider treating the patient in the minimally invasive space, they're typically office-based. Ejaculation is typically not an issue. But with the surgery, you certainly remove the tissue. They're far more durable. And they, as you saw in the previous slides, they offer a greater reduction in the urinary symptom questionnaire that we all use too often in our offices to really measure how the patient responds to treatment. So Michael then proceeds to say that it sounds like there are two water options. You've got the steam option and the aquablation option. What's really the difference? So Resume is a procedure where we use steam, water vapor therapy. It is typically performed under light sedation. It's an outpatient procedure with minimal risks. Very mild to moderate discomfort and a very short recovery time, but the patient will require a temporary catheter for up to a week. And I'm going to play a little video to make it easier to understand what it is. So, like I mentioned, it's a water vapor therapy where we introduce a special device that has a needle that deploys into the prostate and delivers steam for a duration of 9 seconds. That steam causes immediate cell death and we deliver it throughout the prostate. So relatively short procedure. And in 1 to 3 months, what happens is that the excess prostate tissue just disappears and opens up the inner space of the prostatic urethra. Aquablation, on the other hand, it's a powerful heat-free water jet that removes excess prostate tissue. It is a surgeon-assisted robotic technology. It does require anesthesia, and it typically requires an overnight hospital stay. Most patients will complain about some burning sensation for several weeks. It has no impact on erectile or orgasmic function, and nearly all men preserve ejaculatory function, as I've shown you before, roughly about 10% of the failure rates. And most patients do not experience any incontinence. And let me show you what aquablation is. So this is a view of a sonogram. So this is the only procedure that exists. We are looking at the sonogram where the surgeon is mapping what the robot is going to do, the tissue that the robot is going to resect. It is preserving some spaces that allow us to maintain continence and ejaculatory function. And by introducing the device, the water jet will resect the prostate tissue, as you see in this animated video, by this high pressure power wash that allows us to remove the overgrown tissue. So Michael then proceeds to ask, how about UroLift? How does that work? Well, UroLift is a minimally invasive procedure that lifts the prostate tissue away. It's almost like curtains where the implants that are implanted push or pull the prostate tissue away by opening up the space in the prostate, allowing for better urination. And it's an outpatient procedure, can be done with some brief sedation or even local anesthesia with some nitrous oxide. Relatively low risks, and you'll see a recurrent nature. A lot of these procedures will have, some 1 to 2 weeks of some blood in the urine, burning sensation, increased urinary frequency, and most of these may or may not require a catheter afterwards. Let me show you a video on how UroLift is done. So we introduce a cystoscope through the urethra into the prostatic space. This is an animated video where we're now looking at the inside of the prostate, and you can see that it's occlusive. And then we deploy the implants that you'll see in a second. And by implanting those implants, we're pushing the prostate tissue away like curtains and opening up the prostatic urethral space, allowing for more adequate emptying of the bladder. And a procedure like this takes roughly about 10 minutes in the office. So 4 implants were implanted here by opening up the inner space, allowing for more than adequate emptying of the bladder. You see the before and the after pictures here. So Michael then proceeds to ask a very important question. What are the chances that I'll stay off the medicine or avoid surgery in the future? When we look at the initial data that was presented to the FDA when these products were approved, they looked at the 5-year data where on the water vapor side, the resume side, the risk of needing surgery after 5 years was 4.4%, and 15% of patients went on medication at the end of 5 years. On the UroLift side, that early data showed about 13% need for repeat surgical treatment, and 24% of patients required medications at the end of 5 years. On the aquablation side, we see the annualized retreatment rates of 1% per year. So at the end of 5 years, the risk of needing a repeat procedure is about 5%. So Michael then proceeds to let me know that his doctor put him on a blood thinner called Plavix. Would it change my recommendation? The American Urological Association guidelines recommend that patients that are on blood thinners and cannot come off the blood thinners should really have a laser procedure. That is the preferred methodology in this setting. And there are a number of different ways and a number of different lasers that are available in today's marketplace. The green light laser is probably the most familiar, where it is utilizing the technology to remove enlarged prostate tissue. It is similar to a traditional transurethral resection, the Roto-Rooter procedure, as it removes the tissue, but it vaporizes the prostate instead of scraping it off. And like I mentioned, it's often used in those that need to remain on their antiplatelet or anticoagulants for various different reasons. And the risks and side effects, as you can see, it's a recurrent theme where some patients will complain of urgency frequency, some blood in the urine. But what's important to remember, as we move into the more invasive space, the risk of ejaculatory dysfunction is not uncommon. However, the risk of erectile dysfunction is extremely low. There are also procedures that not only vaporize the tissue with the laser, but they actually core it out, like removing the inside of the orange, just leaving the peel. And then what you do with the cored out tissue is you remove it in pieces at the end of the procedure. And it's ideal for larger glands. Most patients can go home the same day, on a rare occasion the next day. It does require general anesthesia, and it does require a catheter. The recurrent theme on all of these procedures is that there's blood in the urine, burning sensation, and the ejaculatory dysfunction is more common than with some of the minimally invasive procedures that I mentioned. So the vaporization and enucleation are the lower risk procedures for higher risk patients, including those that need to stay on their medications due to various different medical reasons. And enucleation for larger glands is possible in an outpatient setting as well. I'm just going to show you a video because I feel like pictures and videos do far more justice than words. So the green light laser fires up, and we introduce it through the cystoscope, similar to all the other transurethral procedures that we do. As you can see, the cystoscope is introduced. That's the laser fiber that was deployed. And then the green light laser, by being in close proximity to the tissue, allows for the vapor bubbles to appear, and it is essentially vaporizing the prostate tissue. So Michael then astutely goes on to ask the questions, can you tell me more about the two newer options that I mentioned earlier, PAE and Optilume? So PAE is prostate arterial embolization. What it does is it shrinks the prostate by reducing the blood flow to the prostate, and it may involve some light sedation. It does not require an overnight stay. It's done in an outpatient setting. Minimal risk of complications, minimal pain, and it typically does not require a catheter. And as my theme tonight, I'm showing videos. Like I said, I love videos because they do a lot more justice than words. So this procedure is done by an interventional radiologist that we'll introduce a special catheter, typically through a groin or a wrist. And similar to a heart catheterization, instead of accessing the heart, they access the arteries that feed the prostate. So here there is a catheter that's being advanced into the right artery of the prostate, and then they deploy little pellets that occlude and block the blood flow to the prostate, and you're basically starving the prostate, and over time it will shrink and allow for the opening of the internal channel and return of better urinary function. The Optilume is one of the newer procedures. It's essentially, unfortunately, I do not have a video for this one, but it is a balloon that is a catheterized, it's a balloon at the end of the catheter that is coated with a medication called paclitaxel, where we inflate the balloon inside the prostate and push the prostatic tissue out of the way. And the reason for the medication coating is that it decreases the likelihood of scarring, and it allows for more smoother healing and keeping that internal prostatic urethra open. I have mentioned a number of other procedures, and just to be complete, the transurethral resection is probably one of the older kids on the block that allows us to remove the tissue through the cystoscope. It is very effective, has had a long track record, and has a proven long-term success, and we still commonly use it today for an appropriately selected patient. It's usually outpatient these days. It is done under general anesthesia. The catheter may be required for one night or perhaps sometimes longer. The risks and side effects, you do have ejaculatory dysfunction that is on the order of 70 to 80%, low risk of erectile dysfunction, some blood in the urine, burning with urination, and again, a recurrent theme on all of these endoscopic urological procedures that we do. The iTind procedure, the temporary implantable device, is a tool that gently reshapes the prostate through a device that is implanted into the prostatic urethra with the aid of the cystoscope. And that device stays there for 5 to 7 days, and it essentially molds the prostate, again, opening up the inner channel to allow for more adequate emptying. There are no indications of long-term side effects with iTind procedure. Most patients will complain of pressure in the perineum, increased urgency frequency. They may see some blood in the urine as well, and burning sensation for the duration of the device being there. The prostatectomies can be done in an open or robotic fashion, and more commonly today, it is a robotic simple prostatectomy. It is a surgical procedure to remove the inside of the prostate. It's a good option for very large prostates, as it removes the most prostate tissue of a lot of these procedures. The robotic technology minimizes incisions, and it speeds up the recovery. Typically an overnight hospital stay, again done with general anesthesia, and requires a catheter for about 7 days. The risks and side effects, it may cause ejaculatory dysfunction. There is low risk of erectile dysfunction, blood in the urine, burning sensation, urinary symptoms that patients complain about. So a lot of procedures, but how do we select the right choice for each patient? It is highly individualized. It's not one size fits all. Just because a patient presents in front of one of us and we happen to like one procedure over the other, that is not the way we approach how we treat our patients. It requires a sophisticated evaluation to select the right procedure for the right patient. So the minimally invasive procedures tend to be of the lower risk category. They are for those patients where the medications don't work or the patients prefer not to take the medications for a long term, whether it's tolerability or cost or just not willingness to take the medicine. The patients are not in retention, nor have any significant indications for doing more invasive procedures. Sexual health and ejaculatory preservation is desired. And for those patients that may not be a good surgical candidate, that is a good choice as well. For patients that are failing medications, have either urinary retention, stones, bleeding in the prostate, even patients with kidney failure from their obstructive symptoms, after appropriate counseling on all the risks, including the ejaculatory dysfunction, surgery is probably the better options. And we tend to favor laser procedures for those patients that cannot come off the anticoagulants or antiplatelet medications. So men with BPH have multiple effective treatment options. The minimally invasive therapies or aquablation are for patients seeking to preserve their ejaculatory function. Laser therapies are for those higher risk patients that need to stay on their various different medications, but no single therapy fits all patients. Treatment selection should be individualized based on the patient's anatomy, risks, and ultimately the patient's goals of where they want to wind up. So I know I spoke for a while. I think there are a number of questions that are out there, and I'm going to stick around for as long as you guys will allow me to, and hopefully we can go through a lot of the questions here. So I'm going to read off the questions so that everybody knows, because I know you can't see them. So the first question is, how often does BPH become cancerous? So as I mentioned earlier on in the presentation, BPH has no impact on cancer. We typically will get a PSA, and if the patient has an elevated PSA, there are other modalities that will exclude the possibility of prostate cancer. So I'm just moving through some of the questions. I'm going to say that, if there are questions that are highly individualized, I'm probably not going to be able to answer it in this form. I would ask that you make an appointment with one of our urologists. We have offices throughout the tri-state area, and a lot of our physicians are well-versed in treating benign prostatic hyperplasia, and we can certainly select the right procedure for all of our patients. So there's a question here. I've been taking 1,000 of pumpkin seed oil recently and do see some relief and flow. Is this a good herbal to take? I'm going to say that, unfortunately, a lot of these remedies have not been thoroughly studied, and there's no data behind these. A lot of these are going to be anecdotal reports and without any meaningful information to back them. But I'm glad that it's working for whoever's asking the question. Urocuff not covered by insurance. Well, insurance is definitely a factor, and there are a couple that unfortunately prevent us from doing Urocuff. However, urodynamics, the one that requires catheters, is an alternative. We can also do a non-invasive uroflow and a post-void residual that will give us that pressure flow study that we're looking for. So there are alternatives. Can medications help and proper diet help? Well, my stance on the proper diet can do a lot of things. And I'm always an advocate for proper diet. And there are various medications for treatment of BPH, like I mentioned, Flomax, alfuzacin, Rapaflo. They can certainly help in the space. And the question really comes down to, is the efficacy enough? Does one want to stay on the medications for a prolonged period of time? It's an individualized question that needs to be addressed with each individual patient with their doctor. Will long-term bladder stones eventually damage the bladder? So there's data to show that leaving bladder stones alone causes a lot of irritative symptoms. There's some data that suggests that there may be some implications for bladder cancer, but I'm more concerned about, if someone is forming bladder stones, to me, that is essentially inadequate emptying of the bladder leading to bladder stones. That patient should really think hard about needing to A, remove their bladder stones, and B, address their enlarged prostate and a long-term obstruction. What is a DRE? DRE is an abbreviation for digital rectal exam. It's that prostate exam that we do in the office to assess the size of the prostate and make sure that there are no nodules or any other abnormalities that we may feel on the exam. The next question here, what are your thoughts on the efficacy of Gemtesa? So Gemtesa is in a category of medications that helps with overactive bladder symptoms. And there are different categories here. There are anticholinergics. You may have heard about Vesicare, oxybutynin. There are a number of others. There are probably about a dozen medications in this space. Gemtesa and Myrbetriq are also for the urgency frequency kind of symptoms. But what you want to be careful about is, are you presenting with simply overactive bladder symptoms, or do you have underlying obstructive symptoms that have led to overactive bladder symptoms, and your bladder is just crying out, help me, help me, help me? So it's, again, an individualized issue that needs to be addressed, and really the patient that is requiring multiple medications to quiet down their bladder because of their obstructive symptoms should really have a pressure flow study, a cystoscopy, and an ultrasound to measure the size of their prostate to see if there are any other options that potentially eliminate the need for the medications. I only drink tea, water, and a small amount of diet soda. Is there any type of tea that is okay to consume? It depends on the caffeine content because, as I mentioned before, the caffeinated products tend to be bladder irritants and will cause increased urgency and frequency. So you really need to test that one out. Are there any urologists who can perform green light laser procedure with bladder neck sparing or ejaculatory hood sparing techniques for avoiding retrograde ejaculation? The simple answer is yes. It is a highly nuanced procedure, but even somebody who's doing the bladder neck sparing and hood sparing operations, there's still an inherent risk of retrograde ejaculation and or ejaculatory dysfunction that needs to be considered and discussed with the patient. What are the side effects of these medications? I would imagine that the medications are this individual is referring to are the common medications that we use in this space: tamsulosin, Rapaflo, Cardura, Hytrin. So a lot of them are very well tolerated, but most common side effects are that you can have ejaculatory dysfunction, specifically Flomax or tamsulosin is notorious for it. You know, one also needs to consider, as we all get older, there are multiple medications that we're taking, and we always talk about that polypharmacy effect. How does one medication interact with the other? So in my mind, it's always a consideration. Can I take a patient off a medication if he desires to come off the medicine and you know, urinate a lot better? Do alpha blockers become less effective when prostate cancer is diagnosed? I don't believe so. The prostate cancer diagnosis does not have any specific correlation unless it's bulky disease, and then it's you know, a different topic to discuss entirely. There are a couple of questions here relating to prostate cancer, and you know, I don't want to ignore them, but I don't think it's the topic of tonight's conversation. So I'm just going to skip over those. What's your opinion of UroLift versus iTind? Well, so iTind is a bit newer than UroLift. However, in a carefully selected patient, both can be quite efficacious. And when I say carefully selected patient, it's important to look at their pressure flow studies, look at their internal anatomy, and make sure that whoever selects the procedure is the best procedure in that urologist's hands. And both can address the issue quite effectively. What if erectile dysfunction is already presently a problem? It's not going to get better, but all of the procedures that we discussed really do not have an impact on erectile dysfunction. Baby aspirin daily, is this okay? It is certainly okay. We are doing a lot of procedures on baby aspirin these days because there are a lot more patients that are taking baby aspirin. But I don't want to be as broad as saying all the procedures are okay on baby aspirin. It needs to be carefully considered which procedure is being selected, and some procedures may not be the right choice for baby for somebody who's taking the baby aspirin. Is a TURP procedure robotic? No, TURP procedure is a transurethral resection of the prostate where we use a cystoscope with a special loop electrocautery that shaves off the prostate tissue, and it is not a robotic procedure. Does an enlarged prostate continue to grow or stabilize? My common saying is that as we get older, it typically continues. And as we saw in the data where patients required retreatments at that 5 years, it's because the prostate unfortunately continues to grow. There's just no predictors of the patients where it's going to grow faster or slower. So it's an individualized assessment. I had a UroLift procedure previously. Would that preclude me from having any other newer procedures if needed? The answer is no. In fact, somebody who's had a UroLift before, you can have the UroLift redone assuming that the patient is still a candidate, and various other procedures are commonly performed with patients who have had prior UroLift implants. How much long-term follow-up of PAE has been done to assess efficacy? So PAE has been around for a long time. However, the American Urological Association guidelines on benign prostatic hyperplasia introduced PAE as a viable option several years ago. And as the data grows, the efficacy is definitely durable and sustainable. And I have many patients who have had PAE and have done amazingly well. What does not in retention mean? So traditionally speaking, urinary retention is where a patient is not able to urinate and requires a catheter attached to a bag to drain the urine. There are some patients that carry a residual urine in their bladder, but depending on the amount of that residual, you can certainly qualify patients as being in chronic urinary retention, but functional, I guess. But it really depends on what that residual is. But the traditional term of urinary retention is really pertains to the patient that requires a catheter. And the one that does not is not in urinary retention. I had a UroLift 3 years ago. I maybe had a few months of relief, a failure in my opinion. What would be next? I would, this is a bit of an individualized question, but this is something that certainly needs to be evaluated. Not every patient will have a sustainable efficacious result from any of these procedures. So there are failure rates for all of them. And if somebody is feeling like their symptoms are not satisfactory, certainly requires a repeat pressure flow study, perhaps a repeat cystoscopy to assess the opening of the channel to really select an appropriate treatment. And if one is deemed a failure, there are a number of other procedures that can remedy the situation. Are PAE or Optilume available, recommended if on a blood thinner? You would have to, so for Optilume, it certainly will increase the likelihood of bleeding. For PAE, it's a consideration for the interventional radiologist that is doing the procedure. It depends on which blood thinner. There may be some contraindications for doing either of these procedures. Why does aquablation require overnight stay? What's the recovery? So the traditional way that we've done aquablation is have the robot ablate the tissue and then not do any cautery at the end. And what I mean by cautery is there are spots in the internal prostatic urethra that are more prone to bleeding. And the initial trials were done without any cautery requirement. However, we quickly learned that that was not the right approach. And the approach now is where we let the robotic system planned out with an ultrasound, do the ablation. The robot is then undocked, and we look in with a cystoscope, look at the areas that are more commonly prone to bleeding and cauterize them. We do focal cauterization, decreasing the likelihood of bleeding. And because of the risk of early bleeding, traditionally the patients would need to stay overnight. As the experience of a lot of us has grown, we are probably sending anywhere from 30 to 50% of patients home. Although it depends on the anatomy of the prostate, the amount of bleeding that we see afterwards, and sometimes the comfort of the patient and various circumstances in that space. So individualized, but not everybody requires an overnight hospital stay. The recovery, so I typically tell all of my patients that, look, we're not going to be friends for a couple of weeks because of increased urgency, frequency, burning sensation, some blood in the urine. With aquablation, you may see a little bit of that grainy particular debris because the ablated tissue is sort of like shedding. You may see an occasional small blood clot. But typically that lasts anywhere from 1 to 3 weeks. And as the time progresses, the symptoms abate and the patients recover fairly quickly. I typically will remove patients from their medical therapy about 4 to 6 weeks out. And by that time, they do not have any significant irritative, that urgency frequency kind of sensation that they had after the operation. There's a question that says, what about radiology? I'm not sure what you're referring to. So if you want to rephrase your question, I'll be happy to address. Doesn't the prostate have a purpose? Why remove it? Well, the prostate secretes nutrients into the ejaculatory fluid. But as we grow older, does it have a purpose? So some of my patients will say, can you just remove it because I can't live with this increased urgency frequency getting up at night to urinate. So the next one I have already addressed, similar, I have ED now. Will any of these fixes repair my ED? It has no effect. It's not gonna make the erectile dysfunction better. Several procedures seem to pierce through the urethra. How long does it take the urethra to heal? Is there a leakage from the urethra resulting from this? We do pierce the urethra, but there's that lining of the urethra that we penetrate with all of these procedures, except for the PAE. PAE doesn't do that. And those irritative symptoms that I'm mentioning, that increased urgency, frequency, burning sensation, are really because of that raw tissue that we create by doing those procedures. Like I mentioned, several weeks, and a lot of those symptoms go away. So that's the typical healing process of that, urethral trauma. And is there any leakage from urethra resulting from this? I'm not sure what that's referring to, but if you were talking about leakage as in terms of not being able to control your urine, no, a lot of these procedures do not affect continence mechanism. Is chronic prostatitis confused for BPH sometimes? Well, so chronic prostatitis is a constellation of symptoms, and certainly, the thought process is it's inflammatory in nature. It can certainly be infectious in nature. the symptoms can be confused because patients will present with, increased urgency, frequency, but what we typically will see in the prostatitis patients, they'll also have a pain component where they'll complain of some burning sensation or pain in the perineal space, that space behind the testicles. Sometimes the discomfort will radiate to the tip of the penis. Some patients will complain about lower abdominal pain, but the symptoms can be confused. But a thoroughly evaluated patient, I would doubt that a highly skilled urologist would necessarily confuse the two. How long do I continue with medications before moving further? Well, it depends. My typical approach to a patient that presents with worsening urinary symptoms, I will put them on the medication and would like to see them in the next 4 to 6 weeks to see how the medications are working for them. And then we have a conversation about, long-term use versus alternative options, depending on the efficacy. And there are some patients that will prefer to stay on the medicine for various different reasons. And there are some patients that will want to come off the medicine and prefer to, use some of the minimally invasive options. And some have moved on to more invasive options, really depending on the symptoms. Medications won't work for everybody. Medications may certainly cause some side effects. Like I mentioned, in the Tamsulosin and Flomax space, the ejaculatory dysfunction is problematic. And I don't recall, but I probably forgot to mention that some patients may experience lowering of their blood pressure, sometimes feel a little lightheaded or dizzy. Rare, but it does happen. What is being done to eliminate BPH altogether? Well, we're seeing a lot of innovative approaches on how we treat prostate enlargement. Up until short 10 to 15 years ago, all we had were you either do a TURP or you go ahead and do a open prostatectomy. Today we have various different procedures ranging from various different surgical modalities and minimally invasive therapies. So we're coming a long way, and the space is expanding as we speak. Is high PSA relevant to larger prostate? The simple answer is yes. And we utilize some tools that allow us to understand the PSA dynamics. Some urologists will talk to you about PSA density, which is the measure of the PSA divided by the total volume of the prostate. Some urologists will also talk to you about PSA velocity, meaning how quickly is that PSA rising. So not every PSA translates into, not every elevated PSA translates into prostate cancer. It is a highly individualized conversation with your urologist. And certainly we take into consideration an enlarged prostate. And the recommendations that you never make a determination of what you do with that elevated PSA based on one number. So definitely warrants a conversation with your urologist. Is there a risk of incontinence as a result of any of these procedures? Very minimal. risk of incontinence is in the single digits. Do medications work for IPP? If not, what mist is best for that? The IPP is, in my mind, as a urologist, I'm kind of leaning towards it's an implant for erectile dysfunction. So I'm not sure what the question is, but I guess the question is, can I have a missed procedure if I have a penile implant? The answer is yes, but it needs to be a selected procedure, and it depends on what kind of an implant the patient has. The next question, I sort of addressed it, but it has a nuance to it. Does PSA increase with prostate size, and how high can the PSA be due to a large prostate without cancer concern? So I can't really speak about a number, how high it can be. Like I mentioned before, it really depends on the dynamics of the PSA. How quickly is it rising? What's the size of the prostate? Has there been any other testing that was done to consider all the variables? Is there natural foodstuff that help BPH instead of supplements? I can't think of any. So I'm gonna draw a blank here. Nothing that readily comes to mind. In general, what priorities do you consider when recommending a procedure for a patient? So that risk-benefit stratification is highly important, and really what the patient individualized drivers are. Does the patient want to preserve their ejaculatory function? How important is it? And do they want a more durable, longer option and don't really care about their ejaculatory function? Although with aquablation, we sort of have a combination of both the highly durable, highly efficacious, lower risk of ejaculatory function. So to me, it's a highly individualized approach. One shoe doesn't fit all, and it's an individualized approach. Methodical evaluation with a pressure flow study, cystoscopy, transrectal ultrasound to assess, and then also marry it with what the patient's goals are. Is there any side effects or dangers from staying on tamsulosin for a long period of time? There were some anecdotal reports that really have not been substantiated, to my knowledge, that had to do with potential early onset dementia. But again, like I said, no known long-term side effects, and that data hasn't really been flushed out. What causes high PSA when everything seems okay? Well, high PSA requires an evaluation. High PSA can be due to various different problems, including an enlarged prostate, urinary infections, prostate infections, certainly prostate cancer, and that needs to be addressed with a urologist. Is it possible that nocturia is caused by a low-grade UTI? Just at face value, I'm not sure what a low-grade UTI is. When there's a UTI, typically a urinary tract infection, typically a patient will present with both night and day urgency frequency, getting up at night to urinate, burning sensation, So if patient simply has nocturia, I wouldn't, necessarily think in line of UTI necessarily. I would evaluate the patient. Which therapy could be done where patient can go home with no catheter? So PAE, the prostate arterial embolization, typically does not require a catheter. Um, Depending on the circumstances, sometimes UroLift may not require a catheter. However, that is decided at the time of the procedure. If there is, a little more bleeding that we expect, we'll use a catheter overnight. But I wouldn't necessarily just avoid a meaningful procedure because of a short-term catheter. I would look at the long-term goals and better urinary function and better bladder health. The next one is about long-term side effects of Flomax. I think I've addressed that. Can you elaborate on ejaculatory dysfunction? Is it the same as the outcome of a vasectomy? No. So when someone has a vasectomy, they will continue to ejaculate, but they simply will not have sperm in the ejaculate. The ejaculatory dysfunction refers to somebody who has a dry orgasm. Are there any supplements that you might recommend that have produced positive studies? Saw palmetto. We do use saw palmetto with patients with lower grade symptoms that are still bothered by them, and some patients will certainly improve. However, those patients need to be observed and make sure that their symptoms are not progressive. That's where we use that urinary symptom questionnaire. We'll use an occasional pressure flow study to correlate how things are progressing. Why does finasteride and PSA readings become obscure? Can you explain why the doctor doubles the PSA lab readings when on this medication? So that is a known fact that finasteride and dutasteride will naturally decrease the PSA, but that is not a true number. And the traditional teaching is that we double the PSA. So someone has a PSA of 2 on finasteride, in reality, their PSA is 4. So that needs to be taken into consideration when looking at the PSAs. How much does weight loss impact or relieve prostate size? So weight loss does not have an impact on the prostate size. They're independent, but certainly, we're all cognizant of being overweight has various different health implications, and losing weight is good all around, but does not have a direct correlation with the prostate size. Is there an infection risk with PAE or other procedures? So there's no direct instrumentation of the urinary tract with PAE, so there is no real concern for a urinary tract infection after a PAE. However, there is a slight risk of a urinary tract infection with any of the urinary tract procedures that we discussed because of instrumentation of the urinary tract. what we do to evaluate the patients preoperatively, we always will check their urinalysis and a urine culture to make sure that there is no bacteria that we need to be concerned about. And if there is, we will postpone the case until the underlying infection can be treated. Does prostate size affect the selection of available treatment procedure? Certainly. The limitations of the procedures that we choose are definitely based on size. In the way that I would probably discuss this is, so for the UroLift patient, the indications are 30 to 80 gram prostate. For the Resume patient, it was traditionally 30 to 80 grams, although they've just expanded their indication to up to 100 grams. iTind procedure is 25 to 70 gram prostate, and aquablation is indicated for patients with prostate sizes of 30 to 150 grams. Some of the larger so PAE can certainly be done on a larger prostate. The prostate enucleation with the laser can be done on a larger prostate, as well as open and robotic prostatectomies can be done on much larger prostates than the ones that I just discussed. And I think that I was able to answer all of the questions. I hope you found this meaningful and enlightening, and certainly happy to address any of the questions. And there is a link in the left-hand corner with all of our locations. And like I mentioned before, all of our urologists in the advanced urology centers of New York are very well versed in benign prostate hyperplasia. A lot of us utilize multiple modalities that I've discussed tonight, and we certainly have specialists that if you wind up seeing somebody that does not do a procedure, we certainly have somebody in the practice that does. And I thank you very much for your attention, and I hope you enjoy the rest of your evening. Good night.